So, this session is about the ultrasound in infertility. What I have to see in infertility scan, whatever we have discussed in pelvic scan, maybe that there is a congenital abnormality, maybe that there is a dyed LFS uterus, maybe that there is a bicoordinate uterus, maybe that there is a fibroid and that fibroid is compressing onto the endometrium, and maybe that there is a adenomyosis, very 3-4 adenomyotic patches, maybe that there is a chocolate cyst, maybe that there is a polyp in the uterine cavity, maybe that there is a very big dermoid over there, and maybe that there is a very thick endometrium which I am taking as normal, which is not normal but a endometrial hyperplasia. Why not a PCODs, which we have discussed? Yes, why not a PCODs, and why not a pelvic inflammatory disease and this endometritis also. So, whatever we have spoken in this female pelvis, we have to take it from A to Z, and in most of cases I will pick something from this. If I know my stuff, I can do wonders with the infertility scan, but provided I will not only take the folliculometry, but before folliculometry I have to see for all these things. If everything is normal, I have excluded from top to bottom, everything is normal, then only please stimulate the ovaries. Then only go for the ovarian stimulation, then only go for the folliculometry, because the cause can be here, not at the level of the ovary in these follicles, growing follicles. Okay, now you know that I am done with this thing, there is nothing from this side to this side, then I will be taking a folliculometry. But before folliculometry, I have to see for all these things. Now, the first thing is that usually I am having some follicles in this ovary, but when a dominant follicle can be seen, it will be usually more than a 12 mm, but when in a baseline scan, for example, I am scanning at day 3rd, at day 3rd, at times I may not comment which is the dominant follicle, but if a follicle will grow, it will have its growth rate. For example, 2 millimeters per day. If today I have seen a 10 millimeter follicle, it is a baseline scan, maybe a 12, 10 will be less, maybe a 12 mm on the right or on the left, and on the left side both are 12, one is 13 and one is 12. Whosoever will grow with the pace of 2 millimeters per day can be even the 12, not the 13 one. So, then I can say that this is the dominant follicle. The point is, please don't keep an eye only on the dominant follicle. See to the endometrium also, because if the follicle is very good, it has ruptured, ova has got released, and now it is fertilized, it is traveling from one end to get dropped into the endometrial cavity. Ultimately, this has to get implanted, which I am not giving much of stress, but I should see with my one eye the follicle and with one eye the endometrium, then only it will make sense. So, there can be a cumulus ovorus. If I am seeing a cumulus ovorus, which is not a very big but a very small 1 to 2 millimeters only, that is the predictor for ovulation. It means that this is the matured, about to rupture. In next 1 if not 2 days it will rupture. So, 1 to 2 days it will rupture, and mostly it will rupture within 24 hours only if I see a cumulus ovorus. So, with cumulus ovorus, if I am seeing inclination from the edge, now see, these are not contours, are not regular here. It means that it is about to rupture. and that is why I am seeing the irregular margins of this Graafian follicle over here, which is about to rupture. So another point which is going in favor of the rupture is the halo. The halo will be surrounding the follicle, and you see a halo and you see a inclination from these irregular margins of this follicle, and if you will be able to pick the cumulus ovorus, these are the signs for the rupture. And here I have to go to endometrium. Hello endometrium, how are you? Do you have very good vascularity? Are you thick enough? Because it has to go here. If I will not see to the endometrium, it will not get implanted, and only one thing is not doing a job. I have to see the endometrium as well. So one more thing, the antral follicular count. If I am taking a baseline scan, not if, I have to take a baseline scan. I am taking the baseline scan at about at day second to third. I have to see antral follicular count. What does this antral follicular count mean? AFC, antral follicular count, means how much I am seeing, how many of follicles I am seeing count wise. If there is no immature follicle, where from the follicle will come? And if I am having a AFC of less than 5, that will be a poor responder. So see this follicle, these follicles, but again I am repeating, this is in this section. In this section I am seeing 1, 2, 3, 4, 5, 6, 7. In this section I am seeing 7. It does not mean that in other section there will not be 2 or 3 more. So I have to take some sections to give the total count. But here I am hardly making out any follicle in any section. So maybe one small over here, or maybe another can be seen in another section. But if it is less than 5, then it is not a good case to stimulate. This is the point. So see for these AFCs when you are dealing with this infertility scan. So the dominant follicle will be any follicle which is crossed the 14 millimeters. Now this is not a matured follicle, this is the dominant follicle. So the dominant follicle mostly is more than 14 millimeters. Now I will be keeping eye on this 14 millimeters, this dominant follicle, for its growth. First of all, growth. How much it is growing? On an average, it is growing by 2 millimeters per day. Now see, this is also correlating here. I am having a 14 millimeters follicle over here, and if it grows by a pace of 2 millimeters per day, in 7 days, how much it will grow? It will grow about a 14, and I had a previously 14, it means the 28. Now see this correlating. This way you can also memorize that it is growing with the pace of 2 millimeters per day. And ovulation can occur anywhere in between. Normal ovulation can occur anywhere in between 18 to 24 millimeters. And as already said, you will see a halo around the follicle prior to 24 hours. And if you see inclination from the edge, and if you see a cumulus ovorus, that is more going in favor of the prediction of the rupture of that follicle in next 24 hours. Now going to the endometrium. Before endometrium, let us conclude this follicle. Now this is the dominant follicle over here. I am putting color onto the dominant follicle. Color, not flow velocities. Color onto the dominant follicle. I will see that if it is more than 70%, if it is more than 70% of the total. Now see here, I cannot say that this is more than 70%. It is about a 50 or 60%. But with this, I can say this is about a 90%, if not more. How? Because on the top it is missing. It is missing from the top. It is missing from the bottom. It is not missing from the sidewise. Here I am seeing the flow like this, but here the angle, the striking angle is 90 degree and here the striking angle is 90 degree. I will slide my not slide my probe, I will take the section from other side. I will now start that this side may be missing by these vessels, but here and here it will be coming. So if you see a vessel which is coming from this side and this side, it automatically means that it is there on the top and in the bottom. So the point here is I should see about a 70% vessel around the dominant follicle. So the dominant follicle is any follicle on Doppler, on color, it will give me more than 70% of the flow around it. So this is what is written here, 3/4 vascularity, that is the 70% and more. And if I see a cumulus ovorus over here, and that cumulus ovorus is nothing but a matured ova over here, these are the signs for these matured follicle about to rupture follicle. These are the all things which I have to see, these polyps over there. So that is why I am skipping between the slides. I have to see for any adenobioses. This is all covered in this in the previous session. So now I will go to the endometrium and I will ask my endometrium, I'm your doctor scanning, how are you? But how? What to see for the air? First of all, I have to see the thickness of the endometrium. The thickness should not exceed 14. It should not exceed 14. And it should not be less than 12. It should not be less than 12. And it should be triple layered. It should be triple layered. I told you in the pelvis classes that this triple layer is due to this inner one, and that is tunica functionalis. So whatever is thickened, why this is thickening? Because the tunica functionalis is increasing. Then what I will do? I will put color. I will put color on the long section, of the uterus, on the long axis of the uterus, like this. I will see for the color where the vessels are going. Now what is the point here? Why I am putting color? The fertilizer ova is coming and dropping into the endometrial cavity. It has to get implanted. What is implantation? Implantation is nothing but the connection with these vessels. If there is a vessel next to this gestational sac over here or an implanted blastocyst over here, it will easily make a connection with the vessel if it is very near to it, and if it is very far, it cannot make a connection. It will lead to the abortion. And I will not make out whether patient has aborted, because it will be like a menstrual abortion like thing. So now there are some zones. The zone first is this thing. What is this? That the myometrium surrounding, now see the myometrium surrounding the endo. This is endometrium here. The myometrium surrounding the endometrium is having a vessel here. This is zone 1. This is zone 1. It is not going in the endometrium, not in the endometrium. It is surrounding, it is somewhere here in the surrounding myometrium, not in the endometrium. That will be zone 1. And what is zone 2 now? Zone 2 is that it is going to the edges of the endometrium itself. It is going into the edge. It's touching or going into the edge, but not penetrating in the endometrium. That is zone 2. And the zone 3 is that it is not now only touching, but it is penetrating in this hypoechoic zone. What is this hypoechoic zone? Tunica functionalis. It is going into the tunica functionalis. That is zone 3, which I need. I need this thing. I need the vessel to be in zone 3. Why? Because I want to perfuse, I want to have some vessels in this layer in the tunica functionalis. That will be zone 3. And if it is going and crossing this zone, this tunica functionalis, so that it is now touching the central canal, this endometrial canal, that is zone 3rd, and that is excellent for patient. Now imagine that the blastocyst has come here, the fertilizer ova has come here. It will easily make a connection with the vessels, but imagine the future of this fertilizer ova which has dropped here, it cannot make a connection. That is why I should see to these vessels, where these vessels are from zone 1, 2, 3 or in 4. Now you all are doing the biophysical score of the fetus. Now I am putting something, biophysical score of uterus, not of fetus but of uterus. What is this? Now see, the endometrial thickness, like in the biophysical score of the fetus, I am taking some points, then I am adding on to these points, then I am giving a score. Same here. How? Endometrial thickness. Now see, if the endometrial thickness is less than 7, straightway 0, and if the endometrium is in between 7 to 9, the point will be 2, and if it is 10 to 14, it is 3. This is what I told you. It should not cross 14. After crossing 14, straightway not 3 but 1 only, 1 only. So the increase in the endometrium is dropping the score, and the decrease is also dropping. It should be somewhere here, in between 10 and 14 for a perfect score, not a score, a point over here. And the endometrial layering. Endometrial layering, if there is no layering, 0. If the hazy trilaminar is seen, only 1. And if I am seeing a distinct trilaminar pattern, then only I can give 3 points. The myometrial contractions, not seen on a still, not seen in an image, but I have something cine loop in the machine. Cine is a small video which is recorded all time by the machine. You can go to that cine to see the myometrial contractions, and if you get any myometrial contractions and these myometrial contractions are less than 3 in 2 minutes, only 0. And if the contractions in 2 minutes are 3, if it is more than 3, then straightway go to 3. Then the myometrial echogenicity. Myometrial echogenicity, overall myometrial echogenicity, if cores are heterogeneous, 1. Then if it is homogeneous, homogeneous means it is like what is here, every part of the myometrium is having same echogenicity, that is homogeneous. For homogeneous, I will give 2 on putting a Doppler. Now 5th is the Doppler. On putting a Doppler where? Uterine artery, which we will discuss in the fetal Doppler. And what is the PI there? PI, if more than 3, 0, and if the PI is in between 2.5 to 2.9, it is touching, then 1, and if it is somewhere in between 2.2 and 2.5, then 2. So what the point here is? Point here is that, what is the point here? Now see the drop. Now see the drop. The drop in the PI. The drop in the PI is increasing the score. Why? Why the drop in the PI is increasing the score? Because this means that I am having an increase in the diastolic flow, not actually the drop in the PI. So lastly and most importantly, I should see for this endometrial flow where the vessels are. This is very important. And if the vessels are not in zone 3, now you know what is zone 3, are not in zone 3, absent, not there, 0. And if it is present over there, then it is 2. And if abundant over there, then 5. So this is very important point, this endometrial blood flow over there, and myometrial blood flow to in turn to arcuate vessels, if absent 0, if present 2. Now see, the point here is not that you have to take one by one, then you have to put a calculator on the right, then keeping on adding to these things. No, that is not my point. The point is what you have to see for. Now see, where is the follicle here? Where is the follicle? Follicle is not here at all. Besides follicle, you have to see for the uterus, and what you have to see in uterus is this thing, is endometrial thickness, is the layering, now see the flow which is going into the, so that it will get implanted. Now these are the points which you have to see. I am not here to dictate you that you have to calculate it by your calculator. No, you have to see to these details in the uterus. Besides this follicle, please see to the uterus like this, and if you will be able to take this and put in one basket, what will happen? There will be a score like a biophysical score, and there has been a study. You may not be able to see what is written here. It is a very big, long study, but I am putting in front of you the moral of the story. The moral of that study. What is the moral of that big story over there? What was written here? That a perfect score of 20 has been associated with conception of 100. But the score of, now see a bit drop. The score of 17 to 90 was associated with the conception of only 80%. But the score of 14 to 16 was having only 60% chances to conceive. But the 13 or less have resulted in no pregnancies. This is the moral of that study. So now, for example, the patient is having a score of 13 only. You will be keeping, giving her clome and all these things to stimulate the ovary, and the patient is not getting conceived. What you are saying? You are saying, I don't know what to do. Bhagwan na deta hai, Bhagwan na deta. It is not Bhagwan na deta. It is that you are not seeing to the uterus where it has to go. The uterine score is very low. You have to first prepare the field, then you have to sow the seed. If you are going to sow the seed in a desert, it will not grow. This is as equal you are sowing that seed in a desert of Saudi Arabia, somewhere here without water and without any minerals over there. So the conclusion is, please see to the uterus also. That is very important. And when you are looking for this follicle, when it will rupture, what are the signs, and what is the growth, by which pace it should grow, that is already discussed with you. So this is all from now for this pelvic scanning. Okay.